Good morning, folks. To round out the instruction that we missed yesterday because of the snow day, I have a patient assessment presentation, and this is a requirement to satisfy your attendance per the program director, the provost, and the dean. So it's important that you view this presentation and then complete the assignment that goes with it, and this is how we can substantiate that you attended class. More importantly, though, this is an important presentation regarding patient assessment, because again, that is going to be the basis of all our patient care decisions. So personal safety is going to be the cardinal rule. The tones are going to drop, you'll be in your station, and following the sound of the tones going off in your station, you'll hear some dispatch information. And it's important that you pay attention to the dispatch information and formulate a plan A and B, perhaps, based on that information and in your mind while you're en route to the scene. And also bear in mind that that information is only going to be as correct as the caller provided to the dispatcher. The dispatcher will be accurate in conveying whatever he or she hears, but again, the person that's conveying that information to the dispatcher might not be accurate. So don't get too married to that information on your way to the scene. Now, once you arrive on the scene, even before you arrive at the address, you should be evaluating the scene, doing a windshield assessment of the scene, paying attention to any unusual dynamics, whether it's a result of weather, unsafe conditions, proceeding or on the way to the scene, that might inform how you want to leave the scene later. Be mindful that you pay attention to any cues on the way into the scene and as you pull up to the location itself. So maintain your situational awareness for all kinds of safety threats, whether it's in the form of, as we said, weather conditions, people on the scene, overhead obstructions of some kind, down power lines. Be aware of your surroundings. Now, when you look at the scene, again, keeping everything in mind, the dispatch information, anything you find on the scene, and as well as your observations of the scene itself. So that could be the appearance of the habitation, the appearance of the home that you're going into. Does it look like it's kept up well or not? That can give you an idea of the physical wellness of the people inside. Possibly, maybe not. So all these observations can play a role in patient assessment ultimately. Now, the hazards that we're going to be looking for, again, could be environmental pertaining to the weather. They might be physical hazards, ice on the steps, obstructions on the sidewalk, animals or pets in the yard. Don't assume it's safe until you can make it safe or find someone else who can. It could be chemical, electrical, and in these instances, if you're unable to make it safe without putting yourself in harm's way, then it's important that you ask dispatch to send you the resources that can do that. Rising water is a huge impediment to your own safety, and you should never try to drive a vehicle across standing water that's even just a couple inches deep. Fire, explosions are obvious reasons to not enter a scene. And then physical violence is a big one that oftentimes can be taken too lightly. And domestic violence calls are fairly commonplace in public safety, and they're hugely dangerous to anyone involved. So it's important that if the scene is violent, then you don't enter the scene. You stage, meaning you park your vehicle, usually not within sight of the scene, and you ask for law enforcement to go into the scene. If it becomes violent, while you're on location. If you're able to grab your patient and bring your patient with you, that would be ideal. But if you're going to compromise your safety in a way that you don't feel comfortable, then you are not required by law to bring your patient with you. You are essentially permitted to abandon your patient if it means protecting yourself and your crew. So that decision is a highly personal one. So as you show up on the scene, you're going to determine the mechanism of injury or the nature of illness. And oftentimes the dispatch information will cue you into this, but it's entirely possible that the opposite of what you've been dispatched for is actually what's taking place, or a combination of both could be occurring. So when we use the term NOI, we're referring to a nature of illness, and MOI refers to a mechanism of injury. And typically we're describing how the person came to be injured. So it could be injuries from a fall, it could be injuries from a motor vehicle crash, it could be gunshot wounds. Any of these things are going to give us a brief description of the mechanism, and oftentimes that may be included in the dispatch information if the dispatcher has it as well. As soon as you leave your vehicle, and in fact prior to leaving your vehicle, based on the information you have, at a minimum, you should be donning your personal protective equipment. Okay, so that could include at a minimum a pair of gloves. If you are dispatched for a motor vehicle crash of any kind, no matter how low speed it is, by Virginia mandates, you're not permitted to leave your vehicle unless you have your safety vests on. So they're highly reflective, they're required, the specifications of which are delineated in the regulations, but suffice it to say that they have to be a fluorescent color, typically orange or yellow, and they have to have a fluorescent luminescent tape on them as well, front and back. Ideally, your agency is going to have those vests stocked on the unit so that you can put it on before you get off your unit. Now, any other risks will dictate additional PPE. So if you get dispatch information that this patient is known to have tuberculosis, then you should put on an N95 respirator at a minimum, as well as putting a mask on your patient. So again, minimal is gloves, and then you can add to that as needed. All of this is taking place basically in those short minutes that you're pulling up to the scene. And if you're as soon as you're able to identify the need for additional resources, it's imperative that you get on the radio and ask dispatch for whatever additional resources you might need. So you can see that we have a list here, a very short list, and bear in mind that that list can be much, much longer. So if you're dispatched for a call and somehow it's not been dispatched as a motor vehicle crash and you're the first unit to arrive, you might be asking dispatch to send you tow trucks, a pumper, law enforcement. If a commercial vehicle is involved, you might be asking for a heavy wrecker, which is a commercial tow truck for commercial vehicles. You can ask for hazardous materials units. You can ask for almost any resource that the county offers. You can simply get on the radio with dispatch and request that. If you have more than one patient, then you should consider asking for an additional ambulance. Keep in mind that even though we may be able to transport more than one patient, if either of those patients is anything other than the most stable BLS patient, then the additional patient needs their own unit, because there's in all likelihood going to be only one provider in the back, and to ask one provider to care for more than one patient is doing a disservice to the patient. Your primary assessment begins when you greet your patient. However, it could be argued that it actually begins as soon as you set sight on your patient. The law hasn't determined when patient care begins. So to assume that it only begins when you actually greet your patient almost absolves you of responsibility. especially if there's something you observe in your patient and you don't act on it. So ideally, one of the first qualities that we assess in our patients is going to be their LOC, their level of consciousness, and their ABCs, their airway, breathing, and circulatory status. As we walk up to the patient, we can start to form a general impression based on what we observe. And again, this is why we can't necessarily say that it begins with greeting our patient, because I might be able to observe certain signs and symptoms in my patient before I even reach their side. So typically what I observe might be changes in level of consciousness. I can determine their level of consciousness often before I can determine whether or not they're breathing or having a patent airway or a pulse. So that tends to be the first observation about our patient that we can make, is whether or not they are responsive or unresponsive. As we form a general impression of our patient, if we find that their level of responsiveness is inappropriate, already we know that that patient is a critical or serious patient. We can also make note of their gender, their estimate of their age, their ethnicity, which actually can play a role in having heightened awareness of certain disease processes, because there are certain disease processes that have a genetic component or an environmental component. Note whether or not your patient appears distressed, noting that appearance of anxiety and distress can often be an indication of early shock, and a general idea of their overall appearance. So when we're talking about their overall appearance, this is often what we can ascertain when we first come up to the patient. Is their coloration unusual? So for example, in this child here, if you look closely and you compare the lips here and even the tongue, we can note that there's an unusual discoloration. That's called cyanosis. That kind of purpley blue cast to the lips and tongue is a cyanosis presentation. Over here we see that our patient is obviously bleeding, and this patient here appears to have an altered level of consciousness. So if we were to see any of these indications, we would have an idea that there's something significantly wrong with our patient, and it would determine the order of how we would assess our patient. Now we also want to consider any unusual sounds that we hear coming from our patients. So I'm going to play this really quickly. This is a sound of an upper airway obstruction in an infant. If it plays. So that unusual sound that you just heard is an example of stridor in an infant. And again, that's an upper airway obstruction. So if you recall in the anatomy and physiology presentation that I uploaded last night or yesterday, that an upper airway obstruction is characterized by an obstruction in the upper airway, which is defined as the part of the airway that is above the vocal cords. So if a patient is exhibiting that sound, that stridor, that means there's swelling and inflammation above the vocal cords, and that's typically going to be in the posterior oropharynx. Other unusual sounds can include gurgling, snoring, both of which are also upper airway obstruction sounds. So those would indicate that the airway is not patent. And if we hear sounds like that and we know that the airway isn't patent, then it would be incumbent on us to take steps to make the airway patent. So moving on, we arrive at our patient and we view them as we did in the last couple slides. We saw that one child that appeared cyanotic. We saw a patient who appeared to be bleeding. We saw a patient that appeared to be unresponsive. So let's start with what we decide to do first. Do we do an ABC check, or do we do a CAB assessment? Well, if we find that our patient is bleeding, as in that one patient that had blood all over his head, then we're not going to proceed with any other part of the assessment until we stop the bleeding. If we find that our patient appears unresponsive and we immediately check for a pulse and we find they are pulseless, we then begin CPR. So circulation refers to pulselessness and bleeding. And if they are either pulseless or bleeding, then we address one of those issues before we proceed with the airway and breathing assessment. If they are not bleeding, if the patient appears to have a pulse because you see that they're breathing or they're talking to you, then we can continue with the ABC assessment. So we're going to assume, or assure rather, that the airway is patent, meaning it should be free of any sounds, that they're breathing adequately, and ideally if they're breathing adequately, we're going to see an equal chest rise, an appropriate chest rise, and the presence and quality of a pulse. So this airway, breathing, and circulation assessment can actually take place all at the same time. You can listen to see if there's any sounds of breathing, because typically the only sound we should hear is air moving in and out. We can look at the chest to see if there's an equal rise and fall while we're assessing a carotid and a radial pulse. So that is one of many ways that you can perform an assessment, an initial assessment as you arrive at your patient.